Okay, good evening, everyone, and a very warm welcome to the Philips Cardiac Ultrasound Med Talk series. Today is our second installment in a series of 5 talks, and we have the pleasure of hosting Dr. Wei Li from the Royal Brompton Hospital in London this evening. Due to the large number of attendees, we will have everybody on mute throughout the presentation. So I'm really thrilled to have all of you here for this educational opportunity, gathered from across South Africa, Kenya, Egypt. We've got people from West Africa as well, and all around the world. I really appreciate that you made the time to join us this evening. My name is David van der Westhuizen. I'm an advanced cardiac ultrasound application specialist for Philips and the Africa team. Let me address a couple of matters before we begin the lecture this evening. Throughout the lecture, should you have any questions for Dr. Li, please type them in the Q&A section that you will find at the bottom or the top of your screen, depending on whether you are tuned in from your laptop, your tablet, or your smartphone. And we will do our best to address these questions during the end of the Q&A session. Saying that, we may not make it through all the questions, but we will attempt to identify as many unique and relevant questions as possible and make sure we've at least answered the most frequently asked questions. So thank you for your understanding. As you are all aware, the World Health Organization has declared the coronavirus outbreak as a global health emergency. We realize that COVID-19 has disrupted our world in many ways. We also believe that learning and education should not stop even in these uncertain times. And from the onset of the pandemic, we have been brainstorming ideas to help with continuous education. Investment in education and its ongoing development is an essential part of the Philips strategy to better serve its customers and to improve quality. As a leading health technology company, Philips has a broad portfolio of products such as ultrasound for cardiac and lung imaging. Allow me to highlight our premium cardiac ultrasound platform and some of its applications. The Philips Epic CVX is our premium ultrasound platform designed for cardiology. It offers users tailored applications for adult, pediatric, and interventional echocardiography with faster data processing, sharper imaging, and robust automated quantification tools. The revolutionary Insight imaging architecture provides images with exceptional frame rate, uniformity, and penetration. We also offer a customizable 2D and 3D user interface. And you have the option, as you can see on your screen, to either customize a feature-rich user interface, or if you prefer, minimalistic user interface. Now, usually 1 + 1 would equal 2. However, in this case, with this very strong combination, 1 + 1 is 3. As most of you will know, TomTec is now part of the Philips family, which is very exciting. In the next few slides, I will show you how we have seamlessly integrated some of TomTec's most trusted applications with Philips technology to bring to our users fully automated and easy to use strain quantification tools. Firstly, I want to highlight our comprehensive auto strain solution. The clinical benefits of strain echocardiography are well established, and echo societies around the world are advocating its routine use. In the cardio-oncology setting, left ventricular global longitudinal strain has been identified as the optimal parameter to detect subclinical left ventricular dysfunction. Philips has a comprehensive strain solution tool set for the left ventricle, the right ventricle, and for the left atrium that is in alignment with the EACVI and ASE Speckle Task Force recommendations. All these applications are fully automated and produce global and regional strain values literally within seconds. The second application that I want to bring to your focus pertains to the right heart. Sometimes referred to as the forgotten ventricle, the right heart is an essentially important part of the cardiovascular system, and understanding its function impacts patient prognosis. For example, patients with pulmonary hypertension. However, for a variety of reasons, the right ventricle can be difficult to assess by echo. 3D Auto RV is a fully automated tool and is the first application that combines Philips and TomTec innovation, offering you a host of both 2D, as you can see on your screen, and 3D measurements. Simply put, 3D Auto RV is fully automated. Image acquisition is easy. The analysis time is fast, thus making 3D quantification of the right ventricle a reality in your everyday clinical practice. It now gives me great pleasure to introduce our speaker for this evening. Dr. Wei Li is a senior consultant and clinical lead in adult congenital heart disease and echocardiography at the Royal Brompton and Hayfield NHS Trusts, and honorary senior lecturer at the National Heart and Lung Institute at the Imperial College in London. She's a frequently invited speaker at international conferences and serves on the European Association of Cardiovascular Imaging Accreditation Committee, and is involved in leading and establishing the European accreditation criteria for congenital echocardiography. She has authored the only textbook on echocardiography in adult congenital heart disease and contributed to over 150 peer-reviewed clinical research publications, and authored by invitation the consensus recommendations for echocardiography in adults with congenital heart defects from the International Society of Adult Congenital Heart Disease. Dr. Li, it's an absolute pleasure hosting you this evening, and it's a real honor for us as well. Welcome. Without any further ado, I'm going to hand over to you. I'm going to stop sharing my screen. I'm going to ask you to share your screen, and then over to you. Thank you very much.
Thank you, David. Good evening, everybody. And thanks for the Philips, who has organized this Med Talk series in this very difficult period of time. I know during this pandemic, people are actually more eager to learn and want to learn more. This is an excellent idea, have this kind of virtual lectures. I think this is where encourage all of us to refresh our knowledges and to learn some new things. I hope from today's talk we can share some of our knowledges with everybody here. So today my talk is about echo assessment of right ventricle, from the basics to advanced technology. Now we know echo has developed a lot. There are a lot of new softwares here. The vet has showed you what you can do with the Philips new machine and the software from the TomTech. I will go through in my lecture about the values of this assessment we use and how we can use them in our routine clinical practice. So without any further delay, let's do a poll question to understand what each of us is doing at the moment. So your blue. So everybody can choose one of these. I just put this question here to see what kind of patient each of you are scanning in every week. Is everybody voting? Maybe we will get the result shortly.
Dr. Li, it's going to take maybe a couple of seconds for us to get the results back. So if you want to continue, and then our team will will share the results once they're ready.
Okay. So I should take this away. This poll should be away. The vet, sorry. You know, this images is on my screen.
Okay, so if you just minimize the poll question, can you do that?
Yes, and also I will, and also the image on my right hand side is
okay. So okay, can we ask our team Njabulu, can you maybe just edit the way we see these pictures?
On my right hand side.
Is that better, Dr. Li?
I still see all of these black squares on my right-hand side.
Okay, I think if you click, you're able to minimize or to change the layout of the pictures on the right-hand side.
That's better now.
Just have a look.
That's okay. Okay, without delay so further. Okay, that's good. We got results. So a lot of you are seeing pulmonary hypertension patient and myocardial infarction patient. This is very common. That is good to know. So we know the rule of the right ventricle is to propel systemic venous blood flow into the pulmonary circulation in a period as short as possible. So right ventricular function is a major determinant of morbidity and mortality in patients with PAH, as well as many cardiovascular diseases such as left-sided heart failure and congenital heart disease. So especially in pulmonary arterial hypertension, right ventricular adaptation is essential to overcome the chronic increase in right ventricular pressure overloading. So here we all know in normal heart, the right ventricle is most anteriorly situated cardiac chamber, and it lies immediately behind the sternum. Here, the 3D reconstruction of the right heart, you can see, in contrast to ellipsoidal left ventricle, right ventricle has complex morphology. From the side view, it shows is a triangular shape, but from cross section, you can see it's like a half moon shape. And also in the heart, there is golden angles between the inflow and outflow and between aorta and the pulmonary artery. These angles are 37.5 degrees. It has a reason with these degrees. Because this can guarantee the most effective flow dynamics. In the disease condition, when the right ventricle dilates, these angles will become larger. This will result in inefficient flow dynamics, reduced cardiac output, hence patient will present with heart failure symptoms. But there are many factors affecting the assessment of right ventricle. We all know it has a complex geometry as compared with LV, has limited definition of its endocardial surface because they have a very coarse tuberculation, and also retrosternal position, and very low dependence of the indices of RV function. This has caused a lot of problems for the accuracy in assessing right ventricular size and function. If you all hasn't learned about how to study the RV, these are two major papers. One is from European Society, European Association of Cardiovascular Imaging, published by Robert Lan. And another one is a guideline from American Society of Echocardiography and published in 2010. So most of what I'm talking is from these two important guideline papers. So first, we will look how we measure the right ventricular dimension. Due to its complex geometry, we must measure the dimension from multiple planes. We start from parasternal long axis view. This is a view we would first imaging we get when we scan a patient. So from this view, actually RV is anterior. You must make sure you have the gain on the tops high so you can see the RV free wall. Here we measure the RV OT proximal diameter, and normally is between 20 to 30 millimeter and is about half of the LV diameter. So if there is an increase in RV dimension, or the RV looks bigger than LV, then you know right ventricle is dilated. Then we move on to the short axis view. There are two diameters you can measure, the RVOT proximal and RVOT distal. They are normal values down here. And then we move to the apical full chamber view, but it's not a straightforward apical full chamber. You have to have an RV focused view. You will see the RV free wall clearly, and also the RV apex. So once you can get this focused RV view, we measure the 3 dimensions. At the base is RVD1, the mid cavity, and also from base to the apex. So all the normal values are showed here. So in addition, for these dimensions, we can also measure the area from this view. We can trace the right ventricular and diastolic area from this focused view. And furthermore, RV we can measure by the 3D imaging of the RV and diastolic volume. So most of you may so busy every day doing many echoes, and you think it's measuring all this takes a lot of time. But there is this qualitative method you can use. I think this is wonderful. We know in normal RV, from the full chamber view, RV is less than LV. Apex is formed by the LV. If the RV and LV dimension nearly equal and they share the apex, then we think the RV is moderately dilated. And if the RV bigger than LV, then that's suggestive of severe RV dilatation. I think this is very easy, simple method to qualitative assess for the RV. So quick glance from apical full, we know whether RV dilated or not. So of course, another parameter we need to measure is RV hypertrophy. Normally RV wall is very thin. So for this, we need a subcostal view to see the RV lateral wall, and normal value is less than 4 millimeters. So about 4, suggestive of RV edge. Now we have poll question 2. Can we bring the poll question 2? So I just want to know, during your routine echo scan, how do you assess RV dilatation? First is by measuring RV dimension from apical 4. And the second is measure a dimension from short axis view, or eyeballing it, or other ways. So while we're waiting, I can carry on. So there are conditions causing RV dilatation, either from volume overloading or pressure overloading. Then there is also, of course, intrinsic myocardium disease. The most common volume overloading condition is we say in left-right shunt, either patient have ASD or anomalous pulmonary venous drainage, followed by the tricuspid valve regurgitation or pulmonary valve regurgitation. Maybe in your practice, you will see more tricuspid regurgitation than the shunt lesion. Oh, that is good. So nearly half of you are measuring from the apical view, and half of you is eyeballing it. I think this eyeballing is also very useful. Thank you. So increased pressure condition, we see most common is pulmonary arterial hypertension. Of course, some patients may come with RVOT obstruction, especially congenital pulmonary stenosis or peripheral pulmonary stenosis. Intrinsic myocardial disease, a lot of you may say with ischemic heart disease or cardiomyopathy. Now we go through some of these conditions to see how their RV will present. Here is the patient. You see, definitely the right ventricle is dilated. From parasternal view, the RV on this view is bigger than LV. On short axis view and apical view, they all the same. This is a patient referred to us through the pulmonary hypertension pathway. So they thought the patient had pulmonary hypertension. What do you think? So the pulmonary hypertension will cause pressure overloading. That's the first should present with RVH. The dilatation only comes later. So one common cause for RV dilatation is volume overloading, isn't it? So this maybe we were easily missed. Actually, this patient had a large ASD because quite posteriorly located, can easily missed. Even on this 2D, you don't see it on this view, but on 3D, on first view, from the right atrial side, you see there is a hole, which has been proved by transesophageal echo. You see clearly posteriorly located large secundum ASD. It's one condition causing right heart volume overloading. And here is a second patient. I show you right ventricle is bigger than the LV from parasternal view, 4-chamber view. Then here's the color just showing you severe tricuspid regurgitation, which is the cause of volume overloading. And this patient, you look at it carefully about his tricuspid valve. He got severe displacement of septal leaflet towards apex and large seal-like anterior leaflet. This is a feature of Epstein anomaly. So this patient had Epstein anomaly with severe tricuspid regurgitation and severely dilated right ventricle. So as we said, pressure overloading can also cause RV dilatation, but the first, or if they are chronic pressure overloaded, they should be presented with RVH, like this patient, you see. The cavity is not big, but RV wall is thick. Of course, we should measure from subcostal view, and on short axis view, another feature of pressure overloading is flattened septum or D-shaped LV. So that is condition of RV pressure overloading. We say in early compensating period, RV presented with hypertrophy. Only later or many years later, when the RV start failure, they present with dilatation. Here's another patient of us. You see, had a VSD device closure. And unfortunately, he developed a continuous increase in his pulmonary artery pressure. When he come to us as a teenager, you can see his RV already dilated. That's suggesting he's developing RV decompensation. That is not very good sign for him. So some of them will have both pressure and volume overloading. This patient had a huge VSD with left-right shunting causing the right heart dilatation. But at the same time, because his age with many years of left-right shunting, he is in his 60s, his RV pressure also increased. But it's not to prohibit for complete closure of the ASD. So in this case, fenestrated ASD closure device was put, which limited shunting. Actually, the patient benefited from this. His heart has shrunk since then. But complete closure may cause a problem because if he has his PA pressure don't drop, still increase, then this can release the right atrial pressure. So this is quite complex condition. So second question when we assess RV is assess the right ventricular function. We know there are many parameters we can use like TAPSE, DTI, and RV performance index and fraction area change. These are all routinely we should use, but most of these parameters are preload sensitive. So like I showed you, when due to the RV volume overload, the right ventricle will usually hyperdynamic. So the parameters we get, they are higher even than normal range. That doesn't mean RV function is good. It's only due to the volume overloading that the numbers are are abnormally high. So there is one sensitive markers may be less sensitive to the preload condition is a speckle tracking measured strain. I will show you in detail. Of course, now we get the 3D measurement of RV volume. We can measure the ejection fraction, and also 3D strain is coming to be useful now gradually. So we all know all these parameters, we need to use different echo parameters to measure, like M mode, we can measure the TAPC and also asynchrony. And 3D, we can measure the volume. Of course, speckle tracking give us a strain rate. I will go through some of these parameters one by one. So TAPC, I'm sure all of you are using it routinely. It's just quickly showing you how we do it. We're just using the 2D apical 4-chamber view, apply the M mode cursor across the right AV junction. You get a trace like this. This is a recorded TAPC. So we measure the RV like this motion from the diastole to systole. So measure this total excursion. This normally is about 20 millimeter. So if less than 16, we think it is abnormal. But this is not only the parameter we can measure. When you look carefully, they recorded clearly cardiac event during the cardiac cycle. This can also be used to study the asynchrony and also the atrial contraction or atrial function after P wave. This part is atrial mechanical function. And of course, we know this TAPC is very easy to use, highly reproducible, and also have a prognostic value. This is a study from our group. In a group of Eisenmenger study, we find if TAPC is less than 15, in the 3 years follow-up, their mortality is more than 30%, as compared with those with TAPC more than 15, their mortality only 5. This is a highly statistically significant difference. So when we do this kind of patient, it's good to measure it, then we can have an idea about patient prognosis. The second parameter we use to assess RV, we often heard, is D-shaped LV. D-shape, that means the septum is flattened. So we measure the eccentric index of LV. It is a perpendicular diameter of the LV, one bisect of the interventricular septum at the papillary muscle level. So you can see if D1 divided by D2 more than 1, then suggesting the septum is flattened. So if the flattened during diastole, that's suggestive of volume overloading, and flattens during systole, usually suggestive of pressure overloading. But in severe pulmonary hypertension, the flattening also happens during early diastole. I will show you later why. So in the literature, we say if the patient had pulmonary hypertension, you can simply just measure the RV-LV diameter at the short axis of papillary muscle level during systole. Normally, if this ratio more than 1, it's already suggestive of RV dilatation, and also can classify a patient with a high instance of event probability. You see the result. The higher the value, the ratio value, the worse event-free probability. Okay, another RV functional parameter is the fraction area change, which is very easy from the RV apical focused view. You just trace the right ventricular area during diastole and during systole, calculate the fraction area change, which normal should be more than 35%. And other parameters we use is the tissue Doppler S wave. This is measures systolic velocity of the tissue. You put the cursor at right atrioventricular junction. During systole, we got this S wave, and we also get early diastolic and late diastolic E and A wave. This also reflecting the regional myocardium function of the right ventricle. And as with other parameters, they are sensitive to the preload. And in the literature, when you look, there is another functional parameter is myocardium performance index, which measures the total time during tricuspid valve closure and divided by the ejecting time. Actually, is total isovolumic time divided by ejecting time. This can also measure on tissue Doppler. It's the same, you just measure the total isovolumic time and measure the ejecting time. This actually reflecting total wasted time over the ejecting time. It shows the efficiency of the heart, of the right heart, and it's reflecting both systolic and diastolic function. In the literature, it's reported has a prognostic value. Now we're coming to this advanced echo we can use now with the speckle tracking, getting this right ventricle longitudinal strain. So the strain is calculated as the percentage of systolic shortening of RV free wall and the septum. You can measure the total and also the segmental. Usually we have 3 segments in the free wall and 3 segments on the septum. So this reflecting the myocardium shortening, they are less volume sensitive. Normal values is more than minus 20%. If less than this, we think it is abnormal. And this is very useful parameters. And in this big study in 575 patients with pulmonary hypertension, you can see that the right ventricular systolic strain is a very good prognostic marker for the all-cause mortality and also for the cardiopulmonary death. The lower the value, the higher of the mortality. So it's very sensitive marker, have the prognostic values. It's very useful now. We should use routinely. This speckle tracking strain not only useful for its absolute strain value, it is also very useful for asynchrony. You can see this right ventricle is really chaotic and asynchronous. But on this 2D, we cannot get a quantitative measure. But with the strain, you can see when we can get the trace, you see, not only we can measure the asynchrony index from R wave to the peak of systole. Some comes early, some comes late, and some are shortening, and some segment is lengthening. So this is very good to show us how asynchronous of this right ventricle, and also where is which segment is asynchronous. This patient, you can see this purple and blue segment, especially on the apical septal part, is asynchronous. Of course, all these RV parameters have its prognostic value. In this study about pulmonary hypertension, you can read the literature. I will not go through very detailedly. All the parameters can give us a good idea to predict, to assess patients with the pulmonary hypertension, which is judged by its percentage predicted VO2. So if you are lower, all the numbers are lower than it's written here, the global longitudinal strain less than 6.5, fraction area change minus 15%, TAPC 13.5%, then your patient is likely to be at a high risk according to the percentage predicted VO2. That is less than 11%, the VO2. So that is really useful. And again, we can use 3D to assess the right ventricular volume and calculate ejection fraction. Now we get very good correlations with MRI measurement, although overall volume is slightly underestimated, but ejection fraction correlates very well. 3D is also useful to study the shape of the ventricle, to look at regional abnormalities. You can see this study is studied patient with idiopathic PAH or connective tissue disease PAH. The right ventricle shape are totally different. In idiopathic, the base is bulging much more and apical also much round. As I showed earlier, this change will change the golden angles. So the angle between inflow and outflow will increase. So heart is much less efficient. This is called functional abnormality. Of course, 3D is wonderful to look at the valve structure. Look at this patient. He had a percutaneous tricuspid valve implanted. You see the tricuspid valve is mounted on a stand. And on 3D, it's beautiful. You can get this kind of on-fast view of the valve in the middle of the stand. It is a wonderful tool. If you have it, please use it. And this is just a list of all the parameters I have talked about their normal range. I think it's a lot of numbers to remember, but don't worry. Take this and look at it when you're doing patients. So now we have a poll question 3 now. So this, I just want to ask you, which of following parameters are you using to assess the RV function? So don't worry what I have talked to you today, but choose the one you are using it. So I just want to know what everybody is using. So I will look at it once the result comes. So pressure overloading of the right ventricle maybe is a very common cause for right ventricular dysfunction because we identify more and more pulmonary hypertension. It can be pulmonary arterial hypertension. It can also be pulmonary venous hypertension, both of them affecting the RV in a similar way. As I said, in the early stage, or if the pulmonary hypertension developed gradually, RV have the ability to adapt by developing the muscle, so become hypertrophied. So at this stage, right ventricle have very good contractility. So good, now we can see, oh, TAPSI, everybody is using it. That is very good. And we should use more and more about this longitudinal strain and 3D after we give this talk. And hopefully you will implement more in your routine practice. So now we carry on. So if hypertrophied RV can no longer compensate, then they will develop eccentric hypertrophy. That means RV will dilate. And when hypertrophied RV become dilated, they usually associated functional reduction. You can see these patients, if you measure every parameter will be done. Fraction area and ejection fraction, strain, all will be done. The mechanisms from adaptive to disadaptive period is very complex. There are many factors affecting it, and the timing to see how long this takes also differ from patient to patient. But clinically, we may see one thing we know is when they have an increased RV pressure, we said, oh, septal motion is abnormal, we say paradoxical septal motion or reverse septal motion. This is clearly seen on MOD. You can see the ventricular septum is coming into the LV rather than going away from LV during diastole. That is because ventricle at this time now is working with RV together, is because the patient had a severe RV afterload increase. And this increased afterload had effect on the LV filling. You can see here, we put simultaneously tricuspid valve regurgitation and the mitral valve opening. So during early diastole, the mitral valve already opened, but the right ventricle still contracting, that still have about 20 to 30 millimeter mercury pressure in the RV. This will impede LV filling. So in patients with severe pulmonary hypertension, you will see there will be blunted early diastolic filling, the filling mostly happening during late diastole and result in left ventricular output decreasing. So this asynchronous contraction actually is a form of severe RV dysfunction. This has been proved on the MRI myocardium taking study. You can see compared with peak systole of LV, RV peak systole comes much later in patients with pulmonary hypertension. And as we can see on Doppler study, due to prolonged systole in pulmonary hypertension, the filling comes late and short. And also due to increased impedance in pulmonary artery, ejection time into pulmonary artery become very short. So we will see most of the time, heart neither filling and no ejecting, is this total wasted time is increased. This total wasted time, we call it total isovolumic time. Actually, in normals, the heart RV is very efficient. They have waste less than 4 seconds per minute. But in patients with pulmonary hypertension, as I showed you with all this prolonged TR, they will have wasted time reaches 10 seconds per minute, which is quite a lot for the heart. That is the reason explained for reduced cardiac output. And this phenomenon getting worse when patients develop tachycardia. You can see here the already severely impaired RV. When they developed tachycardia, heart rate, this is not extremely fast, maybe 120. You see the filling time nearly squeezed out. Hardly any time for the right heart to fill, replaced by the further prolonged systole. So this explains why patients with severe pulmonary hypertension reduced RV function, they will die when they have infection or when they develop atrial tachycardia, because their cardiac output is severely reduced. And on our study in primary pulmonary hypertension, we have found the simple systolic to diastolic ratio. That is very easy to measure. You measure the duration of tricuspid regurgitation as systolic duration and compared with filling time, the tricuspid filling time. So then this simple SD ratio can divide patients by their prognosis. So if the SD ratio more than 1.1, look, their prognosis much poor than the patient with SD ratio less than 1. This has been proved in our study with the Eisenmenger study as well. Of course, the more parameter you have, the more accurate you can be to predict the prognosis. In this Eisenmenger study, we not only use the SD ratio, which has to be more than 1.5, and we also added TAPSE less than 15, right atrial area more than 25, and RA-LA area ratio more than 1.5. If you have these 4 parameters, you are much more accurate in predict the poor prognosis. Look, the ROC curve, the area is 0.9. If we only use the TAPSE, the area is about 0.6. So more parameter you use, the more accurate you can be in assessment of clinical course. Of course, there is also diastolic function. I will go quite quickly. In congenital patient, we see diastolic function in pulmonary regurgitation. We call it restrictive right ventricular physiology, is by presented this A wave on the pulmonary Doppler, which appears after P wave on ECG, so it's during atrial systole. But why during atrial systole, the blood go into the pulmonary artery? It's because the right ventricle is very stiff. They cannot relax to accommodate the blood. So the blood being pushed to the pulmonary artery straight away. At the same time, blood can also reverse flow into the venous system. This is the SVC flow, you see, not only the forward flow into the heart, but reverse flow during atrial systole, very large A wave. This you will see clinically on patient neck. You may see this JVP is raised with a large A wave. That is a sign of restrictive right ventricle. And later on, if the patient have this physiology, they develop heart failure, very difficult to treat with diuretics. And sometimes you have patients like this. This is a patient at age 12 and comes for screening because the mom was diagnosed to have a Noonan syndrome and cardiomyopathy. He's completely asymptomatic. Can you identify anything wrong? So sorry, we can't hear anything. You can see from mode LV measurement, which completely normal. On this, I think you can all agree with me. Systolic function of biventricle looks very good, but atrium by atrium is dilated. So we should look more carefully. So in the old time, we'll record this heart sound, actually. It's very useful. We record heart sound, you can see from the carotid Doppler diastolic notch, we identify this is A2. After A2, there is further additional 2 sounds. So by definition, this is a third heart sound. Then we look more carefully. So first component of a third heart sound corresponding to the left ventricular filling, and the second one corresponding to the right ventricular filling. So indeed, this patient had not only left ventricular restriction and also have right ventricular restriction. And you can see from the IVC flow, had a very large A wave. Then during cardiac catheter, it's not surprising. You see this sign of the square sign. You see the early diastolic fast deceleration, then followed by the increased diastolic pressure. So these patients really have severe biventricular restrictive cardiomyopathy. So my take-home message is anatomy, physiology, and pathophysiology of the RV are quite different from those of the LV. Right ventricular dysfunction can be assessed by its longest axis movement, fraction area change, TDI, tail index, 3D-EF, and longitudinal strain. These are also the parameters recommended to use. You may not use all of them, but 2 or 3 of these parameters should be reported or should be assessed quantitatively during your study. So ECHO provides a versatile and practical approach to analyze difficult problems in individual patients. Thank you for your attention. Now I can get some questions from you. Thank you.
Thank you very much, Dr. Li. That was really a deep dive into the wonderful world of right ventricular function and dysfunction. Thank you very much. That was really appreciated. Okay, so at the moment we have 7 questions. So I just want to remind the delegates that this is your chance. Okay, so if you want to ask something, please type it in the Q&A. Dr. Lisa, I'm gonna fire away with the first question, if that's okay with you.
Yes, I think you can answer. Yes. Sure.
Okay. So the first one, I'm not sure if I understand this correctly. It says, does tracing speckles work for many devices, probably for many diseases? So I think if we can rephrase, on what pathologies of the RV can we use speckle tracking to get perhaps prognostic value?
Excuse me, David, which one you're asking?
This is the very first. This is the very first question. So he's asking on what diseases can we use speckle tracking?
I see.
Yeah.
I think it's a very good question. Speckle tracking is relatively new. So the studies are not as many as the parameter we did for using the other parameter, because they're new advanced echo method. But I think there is a more recently a recognition of the value of spec tracking, because it's less preload dependence, and also they can detect preclinical changes in patients like have cancers, or like patient have no clinical symptoms. I think it's a very useful tool. The more you measure, the more you will find its value. Of course, in every single conditions, you can use speckle tracking.
Okay. Excellent. Thanks, Dr. Li. I trust that answers the question. And then also there's another question, is there any variability with regard to pediatric RV function analysis? So probably
there is. In pediatric, it's quite complex because the age difference. So the normal values varies a lot. When you are studying the pediatric patient, you should find a relevant reference value to compare. They are different from adult.
Okay, so there's quite a difference. Okay, I'm gonna just fine. Let me just dismiss this question. Okay, the third one. Okay, when do we need to suspect pathology when the right ventricle appears to be heavily trabeculated? So I'm assuming the function looks good, but there's very, very heavy trabeculations in the right ventricle. What do we do with this scenario then?
I see. So in my experience, when they have a heavy trabeculation, maybe systolic function is good, but we must pay attention to diastolic function. The heavy trabeculation suggestive of the muscle not relaxing very well. So we should follow with diastolic parameters more carefully. Of course, we should measure the right atria and to check with speckle trackings whether the value is low or not.
Okay, all right. Thanks, Dr. Li. I think that hopefully answers the question. The following one is you've mentioned the RV focused view.
Yes.
At the beginning of the talk. So do you routinely use that in your practice? So for example, if we're measuring fractional area change for most 2D linear measurements, would you recommend the RV focused view?
Definitely.
Or would you? Okay.
Definitely. For RV measurement from apical 4-chamber view, that means RV focused view. If you don't get RV focused view, you are not measured correctly.
Okay, so we it's not really recommended to measure on a 4-chamber then, the right ventricle.
Yes.
Okay. Okay. All right. I think that answers the question. Okay. We're moving to the 3D questions now. Okay. So should we use 3D RV function analysis in all cases? And then in the same breath, but then in which percentage of cases is this possible without going to TEE? Good question.
I think this actually, if you ask the people have been very good doing 3D, they would definitely say yes. Since the new tools with these new machines, the RV, you can measure in about, I think more than 60% of patients, you can get very good trace. And there are a couple of publications you will find they have showed it is RV ejection fraction measured by 3D has a prognostic values. So I think if in your routine practice, if you can do it, you should do it routinely in every single patient. In this way, your skills getting better and your values also getting better.
Of course. Okay. Thank you, Dr. Li. And I think especially if we, I think the software gets easier and easier to do. It's no longer a full-stitch, full volume acquisition. Some of the software makes it really, really easy. So I think we should absolutely embrace it.
Definitely.
The next question is: will untreated sleep apnea cause right ventricular enlargement and end in right heart failure?
Maybe not in all of them. Certainly, very important proportion of this patient will develop certain degree of pulmonary hypertension. Then they develop the right ventricular failure. This is what we can see in our patient population. So most of them need to be checked.
Okay. All right. We're moving towards the kind of the surgery side of things. So the next question is: what level of right ventricular systolic dysfunction could justify surgical refusal for valvular surgery, such as a mitral valve or tricuspid valve repair? So what level of RV systolic dysfunction?
From water, isn't it? Well, this is possibly surgeon should answer this question. This is, to be honest, I don't know really. And because in patients with valve disease, the numbers are usually high. So even normal numbers, you think this is RV is impaired. So what number you would think this shouldn't be operated? I really don't know exactly. We do have these argues every MDT meeting. The surgeon said you want to keep the patient this very sick ventricle sometimes, especially on the right side. After bypass surgery, the RV being damaged further, although you gave competent valve, but ventricle is not working at all. I know a value for the systemic RV, like in congenitally corrected transposition of great artery. This is one condition of systemic RV. From the Mayo Clinical study, they said if the RV ejection fraction is less than 40%, then afterwards you have a surgery, they don't recover fully. So that means you're too late, missed the boat. But for the normal RV, I don't have number to go. Sorry.
Okay. No, that's it is what it is. Dr. Li, just to let everybody know, it's going to be 8 o'clock in 1 minute, but I think it's such very stimulating clinical discussion. We're gonna press on for a few more minutes. If that's okay with you, Dr. Li.
Yeah, sure.
We've got one of our sports cardiologists in South Africa asking any role of cardiac MRI, presumably in the assessment of RV.
Yeah. MRI is gold standard for the RV. If you have my MRI colleague here, they will say, sure. Actually, in our practice, we use MRI a lot, especially for congenital heart patients. For pulmonary hypertension, we haven't been used routinely because normally patients find difficulty in holding the breath. But MRI is very useful because they can see RV as a whole, and they got 3-dimensional measurement of the RV, and also much more accurate in assessing the RV ejection fraction and volume. So I would say it's big rule for MRI.
Still a big role, and it's going to be like that. But I think saying that, I think 3D echo is complementary of MRI and vice versa. Would you agree?
Yes. 3D will help a lot.
Then we've got a question from somebody which is as a cardiac anesthesiologist. So most of the studies are TOE. So he's asking what 2D measurement is the best method for RV function, and then all assessments on TE or TOE, as he's saying, TAPSE is usually not on plane. So what's the base 2D measurements for RV function assessment using TE?
The transesophageal.
Correct. Yeah.
So, you know, that there is not much you can do really, I think, except the TAPSE is not very easy. You can measure the fraction area change, I think, if you measure from the 4-chamber view. That can be a good parameter to use.
Okay, so fractional area change. Okay,
yes,
right.
Yes.
But it's also fair to say, I think, in terms of measurements, the transthoracic echo gives us a lot of information, and only even
don't
more
get images.
yeah. If you can get the images.
That's
okay.
Right.
Right. We still have over 100 participants, so let's press on. The BSE, okay, so the British Society of Echo, BSE, recently published new right ventricular dimensions. Why do their dimensions differ from current guidelines?
I know, you know, right ventricle has very complex geometry. Depends the way you measure it. I'm sure if you measure from different plane at different level, they can be different. But we can only do this much. This is why we have guidelines. In order to do a large comparative study, we have to follow the guidelines. Then we can see, we can compare with each other. If you use individual measurement, then we will not know.
Okay. In your in your department, do you follow the European Association guidelines?
Yes, okay. We use European Association guideline. From these 2 papers I have showed you, I hope they get the reference from this talk. So if they want, you can read.
Yeah, they're welcome just to email me directly. I've got those papers.
These are the 2 main guideline reference papers. If they read, they have most of them. Yeah.
So I think maybe let's tackle just maybe just 3 more questions. Okay. Next one is any value in evaluating the right ventricle during or just after exercise? It's also coming from one of our sports cardiologists.
For the normal values.
Yeah. Any value in any value, meaning is not, are there any value in evaluating RV during or just after exercise?
Yeah, I'm not aware of normal the values like to assess the contractile reserve of the right ventricle, because most of the patients come for the stress echo, they're measuring the LV. Then in our lab, when we gave contrast, the RV actually is very hard to see. I have tried to look several of them, and it's very difficult. But RV actually is very important in terms of determinant for the patient's symptom. And sometimes we missed it because we're so obsessed on LV, we overlooked RV dysfunction. I think this is the area we should do some study on it.
Okay. Thanks for that. Second last question is, please discuss pulmonary hypertension and pulmonary stenosis. But I think this would perhaps be a whole talk on its own. Would you agree, Wei? Okay.
Yeah, definitely. It's very big.
So maybe I mean the MedTalk series will go on, and we can perhaps discuss certain valvular pathology. But I think
I'll be happy to talk about pulmonary hypertension. It's my passion.
Okay, no. I'll take you up on that. And then just a question. Okay, so the final one then is what is the most sensitive and specific index for restrictive physiology? I think that's an excellent question.
Restrictive physiology, to detect, we use this A wave on the pulmonary Doppler. I think to be more accurate, you have to be very careful. It's usually seen in patients with pulmonary regurgitation. Then the A wave have to have a certain high of velocity, normally more than 40 centimeters per second, and has to be present throughout respiration. So if only you occasionally say it's not significant enough. Of course, if you combine with other parameters like right atrium dimension, and IVC flow, SVC flow have this reverse A wave, then it becomes more accurate. Sometimes the volume challenge is very good way to ascertain about the existence of restriction, because when you give volume, this you will unmask the RV restriction.
I see. Okay. Thanks, Dr. Li. That's okay. I think I trust that answers the question. Okay, so we have a few more, but I think I will, if you don't mind, we can answer these perhaps offline. They're coming from one of our big centers here in the Western Cape. I know the person that asking the question, so I will.
Okay.
If you don't mind, we can. I will email them to you. It has gone 6 minutes past the hour. We've got still more than 90 delegates on the line. Okay, Dr. Wei, that concludes our second session. I want to thank all delegates for their participation and engagement. And again, Dr. Li, thank you so much for this extremely insightful talk. It's been very useful. Thank you so much for your time. And a friendly reminder that we have Professor Roxy Senior, also from the Brompton. Next week, he's going to talk about discordant aortic valve stenosis. And the week after that, we have Dr. Walter Serino back. That's going to talk strain and TE in the perioperative setting. Again, all those talks definitely not to be missed. So from me, many thanks for attending. All the best. Dr. Li, thank you again and good night.
Okay, thank you. Bye now.
Thank you. Good night. Bye-bye.
Bye-bye.